I thought about presenting the story of the AVOID clinical trial just like this, like a story. And these are my disclosure. And the only additional disclosure is that this morning during the break, I had coffee only to discover that it was paid for by Baxter. So I have to disclose that. So the AVOID clinical trial has a significant background, persistent congestion in patients that are hospitalized for acutely decompensated heart failure, predicts a poor prognosis, and for those of you that are not in the heart failure world, on a day-to-day basis, persistent congestion predicts a poor prognosis independent of the patient's age and also independent of renal function. So far, there have not been any medication shown to be effective in reducing heart failure events, renal dysfunction, or mortality. And this is why we continue to be interested in veno-venous ultrafiltration. Unfortunately, to date, trials of fluid removal with ultrafiltration has been conducted in different populations using variable protocol and have therefore yielded conflicting results. I don't have to talk to this audience about what an ultrafiltration circuit is about. I just want to tell you that this representation of the ultrafiltration circuit I'm indebted to Claudio, who helped me with the drawing for one of the articles that we wrote. I just wanted to tell you here that there is still a great need of interaction between cardiologists and nephrologists, and that I believe that some of the problems encountered with ultrafiltration are purely related to lack of knowledge, lack of, like Dr. Serda so well said, lack of touching the machine. I'll just give you an example. During a recent lecture, I had a colleague complaining to me about how the hematocrit sensor didn't work on the machine. So I asked to look at it, and seriously, the hematocrit sensor was behind the machine and was not connected to the circuit. So I tried as diplomatically as possible to explain why it did not work and how to connect it to the machine and look at the value once it was connected. The AVOID trial was a prospective one-to-one randomized, non-blinded, multi-center trial, and the aim was to determine whether early isolated veno-venous ultrafiltration prolongs the time to first heart failure event in 90 days after discharge from the index hospitalization compared with IV loop diuretics. And I would like you to really read carefully the last 2.5 lines, when both fluid removal therapies are adjusted according to the vital signs and renal function. The reason I'm pointing this out is because the CARES trial not only was a rescue trial and not an early strategy trial, but the patients assigned to the diuretic arm had a very thoughtful stepped pharmacologic therapy algorithm, whereas the group assigned to ultrafiltration had a one-size-fit-all, where there was one ultrafiltration rate for all patients. So we felt that we should actually adjust both methods of fluid removal according to the patient's characteristics. And I was very happy to hear Dr. Serta say that you have to look at the values even every hour. So the patients were randomized, and then they were monitored every 24 hours at 72 hours and at discharge, and then they had visits at 30, 60, and 90 days after discharge. And here the story starts. The original sample size was 810 patients. We based this sample size on the assumption that the 90-day event rate in the control arm, the diuretic arm, would be about 25%, and that the treatment effect achievable with adjustable ultrafiltration would be 35 to 37.5%. Initially, the study was supported by Gambro until March 2012, when, and then the sponsor was acquired by Baxter Healthcare in September 2013. A few months later, I was called by a representative of the sponsor telling me that the study had been terminated. I tried to wake up from the shock, and then I asked why was the study terminated, and I was told that it was because the sponsor did not consider heart failure an important clinical problem. I pointed out that there are more than 10 million patients in the United States alone that have heart failure, 700,000 new cases, 1.2 million hospitalizations for heart failure each year, and that 90% of those hospitalizations are due to congestion. I was dismissed with the exact word, well, heart failure is simply not on our radar screen. I want to point out that the decision was made without advanced review of the trial data and without prior consultation with the study, the SMB, or steering committee, which steering committee that strongly disagreed with the sponsor decision to stop the trial. The trial was in no way terminated due to futility or safety concerns, and we were able to accumulate 224 patients before the termination of the trial. And although I'm directing my talk to everyone, I would like to specifically talk to my younger colleagues and tell them that they shouldn't be afraid to be David in front of Goliath, because if you remember the story, the little guy ended up winning. So our primary endpoint was time to first heart failure event within 90 days after discharge from index hospitalization. And we define heart failure events as you see here. And the reason for including as a heart failure event unscheduled clinic or emergency room visit in which the patients received IV loop diuretic or ultrafiltration for fluid overload was due to the increasing efforts that are occurring in the United States to avoid hospitalization so that patients are treated similarly to a hospitalization, but in the clinic or in an observation unit. We had several secondary endpoints that you can see here. They were classified according to whether they regarded efficacy, whether they were clinical endpoints or safety endpoints, the primary of which was change in renal function at each interval at 90 days. The patients essentially had to be admitted with the primary diagnosis of heart failure, and they had to have at least 2 unequivocally detectable signs of fluid overload. In addition, because we were testing the early use of ultrafiltration, the enrollment had to occur within 24 hours of hospital admission, and to reflect clinical practice, we allowed that a patient may have had no more than 2 doses of IV diuretics prior to randomization, because many times the cardiologist is called after the patient has received 1 or 2 doses of diuretics in the emergency department. We had several exclusion criteria. I will not mention all of them. I would like to point out that we excluded patients that might need renal replacement therapies, patients that were hypotensive, and patients in whom a venous access could not be obtained, and also patients that require intravenous inotropes. And we consider the requirement of vasoactive agents a treatment failure in both arms, whereas in the CARES trial, the inotropes were included in the pharmacologic arm, but were considered a treatment failure in the ultrafiltration arm. So we wanted this to be a treatment failure in both groups. Obviously, we do not want patients with constrictive or restrictive cardiomyopathy or uncontrolled valvular stenosis, particularly referring to critical aortic stenosis. Like Dr. Serda, you are more than welcome to my slides. However, this loop diuretic protocol is actually spelled out just as it is in this slide in the design paper, which, by the way, the sponsor tried to prevent us from writing. But we did write it, we did submit it, and it did get accepted in the American Heart Journal. But what you can see here is that we recommended an initial dose of diuretics, and then we actually reevaluated the situation every 24 hours, and we provided criteria for adjustment in the diuretic dose, as well as criteria for considering completion of diuretic therapy. We also had specific ultrafiltration guidelines, and although this may seem almost offensive to you nephrologists, we had to say, please, if you decide on an initial UF rate, don't increase it, but rather decrease it during the course of treatment. And we did this because I had many situations prior to the study where I would go to a center and they would tell me, well, we start low, but if the patient is okay, we increase the rate. And I had to, again, diplomatically explain that plasma refill rate decreases as you remove fluid, so it is not a good idea to increase the rate after we have used an initial rate. The choice of UF rate was based on the patient's systolic blood pressure, and we recommended a drop by 50 cc per hour in patients that had renal insufficiency. And also, in our case, and this is an important point, in patients that had right ventricular dysfunction, because in these patients, there is a greater amount of blood that is stored in the venous circulation So these patients are especially susceptible to intravascular volume depletion. We reevaluated the UF rate every 6 hours, and we also provided criteria for when to consider the ultrafiltration therapy completed. The statistical analysis was not unusual for this type of trial. The baseline characteristics were absolutely similar in all patients, including their heart failure characteristics and the laboratory measurements, as well as the medications that patients were on. In the adjustable ultrafiltration group, the average rate was 138 milliliters per hour with an average duration of 80 hours. The number of filter used per patient was 1.7, and there were treatment failures, 7 of which were due to requirement for vasoactive drugs, 1 for need for renal replacement therapy, and 8 were related to device or technical problems. And I think this is, for the most part, from what I have read in the case report form, a case of not touching the machine, and in some cases not touching the patient either, or evaluating the diameter of the vein in which that you use for venous access. In the adjustable IV loop diuretic group, the average dose was 271 furosemide equivalents for a duration of 100 hours. There were 8 treatment failures due to need for vasoactive drugs and 1 that needed renal replacement therapy. This is the primary endpoint, or time to heart failure event after discharge. As you can see, we did not reach statistical significance because we had only 27% of the originally planned sample size. But I think that you can see in these Kaplan-Meier curves that the time to first heart failure event in the ultrafiltration group was 63 days, whereas in the diuretic group was 34 days. Compared to the adjustable loop diuretic group, the UF group had greater total and net fluid loss. There was no difference in weight loss, time to freedom from congestion, and BNP levels at various intervals. I should point out that we did not have the funds for a core laboratory to measure the BNP levels. The clinical endpoints were extremely encouraging because despite the fact that we had 27% of the original sample size, we had enough evidence to show that the adjustable ultrafiltration group had a significantly lower number of heart failure rehospitalization, percentage of patients with heart failure rehospitalization, and also a significant decrease at 30 days in cardiovascular rehospitalization. And perhaps the most pronounced difference was that there was a significantly shorter length of hospitalization for both heart failure and cardiovascular causes in general. Unlike CARES, which showed that UF and diuretic decrease weight to the same degree, but UF had a higher serum creatinine, we did not detect any change, any difference in the changes in serum creatinine at all interval in which serum creatinine was measured. I don't have the time to show you the other data, but the same was true for BUN to creatinine ratio, and estimated GFR, albeit with the limitations of an estimated GFR in patients with an acute disease. These are the adverse events, and you can limit your, for now, to look at the top line where there was no difference in the two groups between serious adverse event or of special interest, which we defined as filter clotting, bleeding events, and progression to requirement for renal replacement therapy. The p-value was 0.122. By 90 days, death occurred in 17 UF patients and in 14 diuretic patients. In the UF group, 71% of the deaths were due to cardiovascular causes, 4 to renal function deterioration, and 1 to a respiratory disorder. In the ALD group, 64% were due to CV causes, 1 to infection, 1 to hypoxemia, and 3 to causes that could not be verified because we also, toward the end of the study, did not have really a CRO. In fact, for additional analysis, we were told by the sponsor that the additional analysis could not be done. The statistician that was helping us with the study was dismissed by the sponsor, was terminated, and the reason we were able to complete the analysis is that in what you would call reverse conflict, I personally paid the statistician to come to Chicago and use one of the SAS computers of the Advocate Heart Institute, and we completed additional analysis, including a sensitivity analysis required by the journal that published the articles. The principal limitation of the study was obviously that it was terminated in an untimely and unilateral manner. We do not know why 60% of the patients were discharged with residual congestion. We were not able to measure blood volume, plasma refill rate, or cardiac performance by echocardiography. Obviously, it was not a blinded study, and we could not do a cost-effectiveness analysis. However, with the data we have, we could conclude that compared to ALD, the AUF group had a trend toward a longer time to first heart failure event in 90 days, significantly fewer heart failure and cardiovascular events, as well as shorter hospitalization for these causes within 30 days after discharge. The number of patients experiencing serious adverse event of special interest was similar in the AUF and ALD group. Obviously, all results should be interpreted with caution due to the fact that we only studied 27% of the planned sample. And as any therapy, decongestion with AUF must balance the benefit of reducing our failure event with the risk of adverse effect. And we believe that UF is not only a done deal, but actually require a lot more studies in patients with heart failure. So looking behind, I think that if I was asked what study would I do next for patients with heart failure, I'm referring to patients with heart failure, I would do an outpatient study to see if UF can be used to prevent rather than treat acute heart failure decompensation. We need to study more accurate methods to measure changes in intravascular volume during therapy to avoid exceeding the plasma refill rate. I would have loved but unable to do a serial measurement of urinary sodium to clarify the candidate selection for UF, the actual amount of sodium removed with UF versus diuretics, and the impact of UF on neurohormonal activation, which were shown in 1994, but at that time, we did not have the guideline-directed medical therapy that included the widespread use of ACE inhibitor, ARB, and now ARNI, beta blockers, and mineralocorticoid antagonist, and also the introduction of less invasive, reliable, and low-cost venous access. Thank you very much for your attention.